We are pleased to provide the video recordings of Florida Digestive Diseases update held on December 4th and 5th, 2021 in Orlando, Florida. This is the video recording from Session 5 on inflammatory bowel disease. In this session, we featured lectures on Biologics and IBD When to Start by Dr. Shen, followed by Biologics and Small Molecules in IBD When to Switch by Dr. Gary Lichtenstein. The third lecture was on Preconception and peripartum management of IBD by Dr. Marla Dubinsky, and the final lecture was on managing IBD in the era of COVID vaccinations by Dr. David Schwartz. The session was concluded with case presentations and discussions with Dr. Uday Kumar Navanethan. Please enjoy the session.
My name is Rob Hawes, and I know nothing about IBD. I'm just a token person up here with a big voice, so I can project to the back and keep you guys in order and so forth. This session is going to be run by Uday Navanethan. Uday is a wonderful partner of ours. He did his fellowship and advanced fellowship at Cleveland Clinic. Worked primarily with Shen and is an expert in the endoscopic management of complications of IBD. He's running our IBD Center of Excellence at Orlando Health, and it's really he is the one that's put together this program for this morning on IBD. We'll run this session the same as we've done before, where we will have the presentations, and then at the end, Uday will present some cases to try to bring out some new ideas and so forth, and that will be the time for you guys to ask any questions that you might have regarding IBD. So, Uday, take it away.
Yeah. Thank you, Rob, and good morning, everybody. It's a pleasure to be back in, and we'll start this morning session with IBD. So, we have some great presentations this morning. We'll start off with the first presenter. It's going to be Shen. I know Bo for probably almost 13 years now, since I was an intern in internal medicine way back, 2009. So I've been working with him since then. Collaboration started since then, and he's been my mentor, friend, colleague, and a great person. He's always a great speaker. He keeps the audience engaged, and he's going to be a wonderful person. So he's currently the professor of medicine and the director of IBD at the Columbia University School of Medicine. And it's a pleasure to have you, Bo, to talk on the topic today. He's going to talk on biologics, when to start. It's a common question everybody asks. When do you start biologics in a patient? When do you make that big jump from ASA or immunomodulator to a biologic? So he's going to try to answer that question.
Thank you, Uday, and thank you, Rob. And again, I really thank as all the meeting organizer and Orlando Health and inviting me back. So actually, I am a IBD interventionist and a pouchologist. They asked me to talk about when to start the biologics. Actually, it can be the challenging topic. But now when I do the endoscopy for the people with the IBD, with the structure, with therapy, if I have a hard time to do the structure therapy, then first the people I blame, number one, I blame surgeon. Number two, would blame the primary care for GI, that lead to the structure formation. Just the blame game of the joking, So, okay, so this is a natural history of the Crohn's disease. So the majority of the patient at the time of the diagnosis had the inflammatory phenotype of the IBD. Now, as the time goes by, 5 years, 10 years, up to 20 years, and the majority of the patient has some form of the complications, either structure, fistula, abscesses formation. Now, that leaves us a medical therapy at the window period at the 3 to 5 years, first 3 to 5 years. And then after 5 years, complication happen, you know what? Now you need an endoscopist, you need a surgeon to help you. So that's why how do you deter that or postpone that disease process? The early intervention, close disease monitoring is the key. Now, this is the slide showed a similar concept. You can see the disease relapse, flare-ups, remission over the years, and then complication happen. Then after surgery, then you restarted the circle. So here's like a life like a circle, and then people with IBD life is a circle too. We started the medical therapy, you have a relapse, remission. In rare occasion, especially with these elderly and 80, 90 years old, the IBD may get a burnout. But the majority of them with the IBD, they carry the rest of their life. Then over the years, you have the fistula, stricture, abscess formation, you had the surgery. And after surgery, if you do not do any intervention, 80% of the people disease will come back. In addition, IBD surgery associated more complication than other colorectal surgery because just the nature of disease. So that's why use the circle, and then you restart the circle. Post-operatively, disease recur, then you treat it again. So now the endoscopy rule, it is try to defer the surgery for the IBD, and then after the post-surgical complication happened, then you treat it with endoscopy, structurotomy, fistulotomy, etc. So then when you talk about how to intervene the patient, it's the timing of the biological therapy. So do you want to start this therapy here? So I use the biological therapy earlier. You can see the arrow is bigger, that it means more effective. Later on, when you have the disease progress, you have the structural complications and the fistula complications, then efficacy, even the most potent biologic agent, even the combined biologic agent, the efficacy is limited. Same thing here. Then after surgery, you reset the clock. Then you started the biological agent again. So like life, like a circle. Now, what's the goal of the medical therapy for IBD? We induce and maintain the tissue healing, prevent the need for steroid, and restore physical growth, especially in children, prevent the stricture and other complications, and reduce hospitalization and colectomy, and decrease the long-term cost of the cost related to healthcare. Now, this is the slides. A lot of people use it. It's a pyramid or step-up therapy. We started with this in the setting of the Crohn's disease. Antibiotics, mesalamines, then corticosteroid, immunomodulators, and then biologic agent, and then the surgery. Actually, has been a big fan of immunomodulator 6MP. I used it for many years, many decades actually, until the 2015. I have 2 patients develop lymphoma. That killed my appetite. Every time I saw the patient with all missing teeth and the hair is gone, so that stings, sort of like the impact of my practice. So that I switched since 2015, more biologic agent. I minimally used the immunomodulator. So this just a coincidence happened, 2 patients. Now, you early start, of course, the better, right? So you can see the disease duration is a relationship with the response. This is the anti-TNF-alpha in the previous clinical trial, the randomized controlled trial. The disease duration shorter and efficacy is better. You have the CHARM trial and ACTION trial, SONIC trial, say the disease fresh, the disease respond, the better. But however, biologic agent is not like a risk-free. People ask me, say, what's the worst case you have when you use so many years to use a biologic agent? I can tell you the worst case I have, it is anti-TNF-alpha associated autoimmune hepatitis. I have the multiple sclerosis, several patients, and I have the psoriasis and the SLE. So the concurrent autoimmune conditions, the paradoxical autoimmune condition developed after biological agent use, especially anti-TNF-alpha, you should pay attention to that. So that's all the biologic agent is not risk-free. So that's why you always balance risk and benefit. So AGA now is a guideline. So the highlighted here, red is recommended, and here highlighted here, pink is suggested based on the evidence. We said it's like anti-TNF-alpha is used for the induction and the maintenance. Vedolizumab, over no treatment for induction and maintenance, as well as Stelara. Now, no natalizumab or Tysabri, because the PML risk. In biological naive patient, you have a choice adalimumab and infliximab, and so as vedolizumab over Cimzia. If the primary non-responder you use to the anti-TNF alpha, you have a choice is Stelara and vedolizumab. If a secondary non-responder to infliximab, you have a choice, it's adalimumab and Stelara, and then Vido is highlighted here. It is pink or suggested. Other two is recommended. Now, we do not use the 6MP azathioprine for induction, but we can use for maintenance. If you want to use the methotrexate for the induction or maintenance, you do the sub-Q form or intramuscular form, not oral form. So this is an important concept. The biologic agent, you use a monotherapy is better than immunomodulator. If you use a combo therapy with a biologic agent, together with the azathioprine is over the biologic agent monotherapy. Now, so people always ask when you do the vedolizumab or the Stelara, should you use the combo or use the monotherapy? Here's no recommendation yet. And then quiescent Crohn's disease, recommended. This is the guideline for moderate to severe luminal Crohn's disease. You will say it is if you have a quiescent disease for Crohn's disease, and should you withdraw the biologic agent, AGA guideline do not recommend withdraw. And then when you have you should, if the patient started with a mesalamine steroid, you should not wait until their failure, and then you start a biologic agent. You can start early. And then corticosteroid is only for induction, never used for maintenance. So actually it's interesting for the people with the moderate or severe Crohn's disease, no mesalamine is recommended. For Crohn's disease, perianal disease, the infliximab is still as a first choice, followed by adalimumab, Humira, Stelara, and vedolizumab for induction and maintenance. No antibiotic alone for perianal disease, but if you use the perianal disease for Crohn's disease, use a combination with the biologic agent together with antibiotics. Now, this AGA guideline is based on the disease activity. It's a moderate to severe disease. Here is what is moderate to severe disease is based on the so-called CDAI, the Crohn's Disease Activity Index. So where's the Crohn's Disease Index came from? So the Crohn's disease, actually the component of the CDAI is mainly symptoms of presentation and the body weight, a little bit of the blood test. But they didn't mention about disease location, extent, and phenotype. So that's the shortcoming of this CDAI-based disease activity classification. Now, there are some contributors for the poor prognosis. Deep mucosal lesion, extensive disease, stricture, fistula, perianal abscess, the prior surgery, especially the bowel resection for 40 centimeters, presence of the stoma in the lab if you have the anemia and the CRP high and the hypoalbuminemia or bad symptoms. Now, impact the structure on the efficacy of the biologic agents. So you will know this is the left side, it is the normal mucosa, and the right side is the disease of the Crohn's disease. So you have the destruction of the layered structure and it has a transmural inflammation with abscess, fibrosis, and shown here, the transmural disease. Now, this is three phenotype of the Crohn's disease. Left side, inflammatory. In the center is stricture, and then the last one is a fistula. So now clinical trial are listed here, our randomized control trial, the biologic agent. Now, during the clinical trial, and you know what? The exclusion criteria include all the strictures. The stricture obstruction were excluded. So when you run the clinical trial, that basically it is the inflammatory phenotype of the disease. So structure is our enemy. Now you will see is with extensive biological agent use, we noticed some structure from the left side pattern called ulcerative structure. The right side is a non-ulcerative structure, but you can't pass even pediatric colonoscopy through it. You can look at the histology with a normal overlaying mucosa, but underneath it, you have a fibrosis, even have a neuronal hyperplasia. Now here is even the mucosal fibrosis that happen in the submucosal fibrosis happen in ulcerative colitis. It is estimated that 14–15% of the people with ulcerative colitis can have the fibrosis, and especially in the rectal area, in the rectal sigmoid junction area. Now, worst of all is the long-term and the inflammation can be associated with the dysplasia. Now, some of the dysplasia can be buried, as shown on the right, so that dysplastic lesion can be buried underneath of the mucosa. It gives the endoscopy a harder time to survey. So that's why the early controlled disease, adequate controlled disease, you can help the deterred or reverse that process. Now, people always ask you when you do the structure therapy, the endoscopic structure therapy, said, can any medicine way to help? Theoretically, it can. If you can divide it into the structure into inflammatory structure with a fibrotic structure, but I do not trust the CT and MRI to differentiate these two. I think that but in the future will be like the ultrasound elastography to differentiate the left side is an inflammatory structure and the right side is a fibrotic structure. And then if the patient had a mixed structure, inflammatory structure, you offer the patient for the endoscopic therapy on top of the medical therapy, especially biologic agent. So we do not have actually the effective drug to reverse the fibrosis yet. So impact disease location and the efficacy of the biologic agent. That is missed in the AGA guideline. So my important concept it is, if you have a disease in the stomach, either in the stomach, or if you have disease in the duodenum, you do not wait. Even if the mucosal inflammation, you start the biologic agent. If they have a disease that have the anal rectum and perianal area, you do not even start like the steroid. You would mesalamine, you need to jump on the biologic agent, especially anti-TNF-alpha, because those diseases you need adequate control. Otherwise, the consequences is bad. And the most important one, you do not have a great surgical option for those patients if you have disease there. So now if you have a disease in ileum and the colon, you can start with some mesalamines, you can start with some antibiotics, you can start with some steroid and an immunomodulator for the mild to moderate disease. So now here is the challenge in the endoscopic therapy. I would have anorectal disease when the structure is very hard to treat, and because also this anorectal structure, there's no surgical option. Number two is a colon structure. It's a middle of the colon structure, very hard to treat, and they have to run the high risk for perforation if you do endoscopic therapy. And if you have the jejunal disease, duodenal disease, the endoscopic therapy can be very hard. Now, there's somebody chasing us, which is colorectal surgery. So there's a randomized controlled trial, the freshly diagnosed with the terminal ileum disease. They offer the ramificated therapy versus bowel resection. Actually, you can see the benefit of the surgical upfront surgery is over the Remicade. So don't even start the biologic agent. Now you have a choice between the surgical therapy at upfront versus medical therapy. Now, who will choose? So this is the one I summarized the two areas at the surgical therapy advantage and disadvantage. When you assess the risk factor or predictor, there are 4 tiers of the risk factor and the predictor you need to study, you need to assess. So what's the risk factor for aggressive disease or poor prognosis, such as a young age at onset, extensive disease, early development of the fibrotic and fistulizing disease? And the next one is what's the risk factor for poor response to the biologic agent, young age, female, fibrostenotic and fistulating disease, prior exposure to anti-TNF-alpha, and prior surgery. And what's the risk factor for post-operative complications? Old age, the low albumin, corticosteroid use, prior to bowel resection, and what's the chance of the post-operative disease recurrence? So they're using this 4 tiers assessment of the disease activity. Now, this slide used a lot, the treated to target. What's the treated to target happened? In my practice, what it be is every time if I adjust the medicine, step up medicine, step down the medicine, 3 months later, I check the lab and then colonoscopy. I use the colonoscopy as the main tool to monitor the response. I need to make sure that the mucosa healing is achieved along with the patient symptoms and the lab improvement. Here's my last slide. Early start of the biologic agent depend on disease severity, disease location and phenotypes, and assessment of the risk factor and the predictor. Aggressive disease, response to medical therapy, and post-operative complication and post-operative recurrence, and close the monitor disease activity and the response to medical therapy. Thank you.
Thank you, Bo. Next, it's a pleasure to invite Gary Lichtenstein. He's a professor of medicine and the director of the IBD Center at UPenn. He's like a walking encyclopedia of IBD clinical trials. I've known him for the last 5 years. He can spit out any clinical trial with the data on top of his head. So it's a pleasure to have you, Gary. And he's going to talk on a very important topic, when to switch from, when you see a biologic small molecule, when do you make the decision to switch from existing drug to a new drug?
Thank you, Uday, and thank you, Bob. Terrific course, as always. And I saw you in the hall, and I said, aha, I haven't seen you in a while. And, you know, it's nice to get back into real life and see people again. So Uday asked me to talk about biologics and small molecules, when to switch. And that comes up a lot in clinical practice. So what I'd like to do is talk about some of the therapeutic treatments we have and clinical scenarios when you should switch. Specifically, what complications come about and when do you say, I need to switch because of it's not working. And also some of the data on optimization. So we recognize that the biologics are the best agents that we have to treat patients. With regards to therapeutics, they work better. They clearly come with baggage. As you know, you've heard Bo talk about that there's clearly baggage with lymphoma, et cetera. But again, you have to say the punishment must fit the crime. If the disease is aggressive, you have to be aggressive with your treatment appropriately. We have different algorithms to treat patients based on expert opinion rather than high-quality evidence. You saw some of them that were placed up there, and we don't have evidence for everything, but it's more eminence-based medicine as opposed to evidence-based medicine. Common scenarios where they're optimized are published, and we're now updating the Crohn's guidelines for ACG. David Rubin has updated the UC guidelines. You'll see those coming out shortly as well. So when to stop therapy also you should say. When do you position therapies? Well, it depends on the scenario. Disease, is it Crohn's or ulcerative colitis? Is the age of the patient such that you wouldn't want to use something? What's the severity of the flare? Is a hospitalized severe colitic in hospital? Well, then you don't want to use something like, say, vedolizumab. That takes too long to gain benefit. You might want to use infliximab. There's data on tofacitinib off-label. A host of different things might come into play. Are they refractory to conventional therapies? If so, which agents and were they optimized? Was therapeutic drug monitoring done to look at that? Do they have fistulae? Do they have extraintestinal manifestations? And we never really talk about that at meetings much, but patients may come in and have severe debilitating extraintestinal manifestations despite treatment of luminal disease, and can you better treat that and serve that with appropriate medical therapeutics? Is it a post-op patient? Is it newly diagnosed? What's the prognosis of the patients? And we don't have to do this step up anymore. That's years ago. We look at the patient, we prognosticate, and we go ahead and say, let's treat them according to the disease prognosis. If they have Crohn's, we don't use mesalamine. It's inappropriate to use. We use biologics to treat those patients directly. And does the patient have adverse events that preclude us from using particular agents? CHF, multiple sclerosis, optic neuritis, old TB, these are people you think secondly about using an anti-TNF and might go to another agent directly. So when do you switch? Safety. That's always a big issue. You have to look at, is it safe and appropriate for the clinical scenario you have the patient? If there's a lack of benefit, you want to optimize. Stay within class, because once you switch to a second biologic, a different agent, your benefit goes down. Your best benefit is the first biologic you have overall. When we look at all the trials, those that have been exposed to second or three biologics do worse. If there's an adequate drug level and no antibody, increase it. Shorten the interval, increase the dose, whatever the biologic is. If there's extraintestinal manifestations not being treated that are significant, then you might consider switching agents if you've optimized the agent you have, and it depends on the EIM that you're talking about. If there's a new malignancy, then you might switch. If someone has melanoma, stage 2, you want to get them off that anti-TNF, and you consider something like vedolizumab in that particular patient. And there's also good data for ustekinumab. There's no black box warning for malignancy or infection using these two agents as of yet. And it looks very safe based on the data we have. And then also the rapidity of onset and disease severity, if it's not adequately treated, then what happens is the patient goes with significant symptoms long term. We'll often use corticosteroids as our bridge. And obviously steroids have twice the mortality, twice the severe adverse infectious complication rates based on a lot of studies in the literature directly showing this. So we've evolved, and these are some of the agents that we have now. Look at the timeline going back to the 1950s, sulfasalazine. We really have a lot. We have at least 25, 50 pipeline drugs that are in various stages of development. So this is going to expand. It's not just one drug fits all. When I started, it was azathioprine, sulfasalazine, and corticosteroids. And this new drug, mesalamine, aka I'll put a brand name out there, Azicol, was coming to market. It was available in Canada. This is going to cure IBD. That was a statement when I started out. Boy, has it changed. We have 3 pillars of care, and this is a slide borrowed from John Frederick Cullum Bell. I like this slide, so I bring it up. Early intervention, treat to target, and tight control, and patient communication is at the base of this because it's critical to communicate to the patient, discuss with them, and do consensus with them and say, hey, this is what we're thinking about, this is why. Do you agree with that? Would you like to proceed? When we treat to target, as Bo had said, we have an aim to avoid complications and disability with a chronic disease. We treat to the predefined target endpoint with long-term outcomes. It's a goal-oriented approach. And we have a strategy, ongoing and regular monitoring, similar to diabetes, hypertension. We monitor, we change, we optimize based on the added benefits. And then the principles are target the treatment and monitoring and tailor to the needs of the individual patient. One size does not fit all. And de-escalate in certain scenarios when you need to. And then the target. You want to be a target engagement specialist in IBD is what you really want to be. So when we look at this, is it target feasible in IBD? And we say, yes, it is. Is it symptoms? Is it labs? Is it mucosal healing? Is it the biologic deep remission? I think we'd like to get all of these together and optimize this for the patient. We have specific recommendations in Crohn's disease where we look at patient-reported outcomes, which are becoming more popular and obviously most important to the patient. I think in all the trials we do, we've really not focused on patients. We've focused on regulatory endpoints that the FDA requires and the EMA requires in an effort to get drugs to market. But we haven't said, what do the patients want? And there's now multiple different studies ongoing looking at these in an effort to better focus on the patient. The same thing is with ulcerative colitis. We have patient-reported outcomes that are secondary endpoints from the trials derived, but not primary target endpoints, if you would, as a primary endpoint, because the FDA and others have not allowed that. Endoscopic healing does better with outcomes. A recent meta-analysis published. Odds ratio, overall ulcerative colitis, 4.5 for clinical remission at 52 weeks. Colectomy-free survival, 52 weeks, 4-fold. So you get that healing, you do better. The same thing for Crohn's, if we could back up one, directly as well. Not quite as good, but good. So almost healed in Crohn's and healed are equally as effective. If you have 3 aphthous ulcers in the ileum and you had severe colonic disease and the patient saw you initially, you've done well. You don't say this is time to switch. Whereas if you have 50% of your colon still inflamed and you're not quite there, then it's time to get back and punt. Try another agent if that agent's been optimized. So we go through these directly. We look at each particular thing. The issue is, does it improve outcomes? And yes, it does if we get to the target that we're trying to get to. Diabetes, hypertension, rheumatoid arthritis, all disease states have these endpoints that we strive to get to. There's different ways to get to the target. Recognize symptomatic improvement with patients is inadequate. It's not the only thing. We have to trust but verify what we hear endoscopically. Proactive therapeutic monitoring versus reactive, and I'm a fan of proactive. Reactive certainly is not a bad thing to do, but you're waiting then until the patient has symptoms. And it's better to do things before they become symptomatic. And there are trials that don't show benefit, but they have major flaws in the design of the trials, the way they were done. Set a goal. Stay on top of the patient. Don't wait till they come back. Go to them. It requires more work. You need an NP, a PA, yourself to call that patient and say, you haven't done what you need to do. It's now a month out. Let's check that lab again. Don't just start the right medicines, optimize them. So it takes a little extra step. It's more work in this day and era where we're doing enough work as is. It's more involved, but you get better outcomes for patients. So a cycle of management, I'll just go through here. We initially treat, and then I'm going to go and focus more on when to stop. So this is too small to read in this audience. But I'm just going to say, you assess the patient, you choose your drug. 3 to 6 months later, you reassess, but in between, you check laboratory values, calprotectin, CRP, whatever it is that that patient has that's elevated, you follow. You look to see, does it normalize? If it's not better, then you need to consider looking at the mucosa. If it's better, then at 6 months or so, look at the mucosa, has it healed? Do a CT and MR enterography to see if the small bowel is improving. If it is, stay that way. It may take time. If it's not, increase the dose, shorten the interval, or switch drugs if you've done that already and optimize. And I think that's what it comes down to. And then every so often, go back and look again to see, is that maintaining the state? Measure the drug levels, look for antibodies that come about. Ustekinumab, vedolizumab, low-level antibodies. Anti-TNFs, often combo therapy or high drug levels, are the keys to keeping that at a state of well-being. So we position therapies. Which is first? TNFs, vedolizumab, ustekinumab, tofacitinib, ozanimod. How do you pick and choose in ulcerative colitis? Well, there's different things you have to look at. With the TNFs, there's perhaps a risk of lymphoma. The Lemaitre study suggested a 3-fold risk. Other studies have not borne that out. If the patient has had a lymphoma, one would not rush to use that as a drug. There's vedolizumab. The long-term safety looks very good. It's IV. There's now 2 studies that have looked at sub-Q. It's available in EU as sub-Q. 108 every 2 weeks is a dosing that's approved. That'll likely be coming to the U.S. as well as infliximab sub-Q is approved, and it's available in other countries. So that's likely coming to us as well. Ustekinumab, it's a slower onset in Crohn's. In UC, it's rapid. It works for psoriasis and psoriatic arthritis. So if psoriasis is a problem, choose that drug. It's an excellent choice. Tofacitinib has gotten a lot of black box warnings recently. So the thing is, these we can talk about. They're not necessarily an IBD, but they've been seen in other diseases, for example, RA. And hence it's been translated to a whole class. This, quote, is an effect that may be seen. And this has created a label change for the upcoming agents that are currently in development, the JAK1 selective inhibitors. And then ozanimod, rapid, oral agent, monotherapy, works quite well. And there's clearly some risks with that we can talk about. So the positioning of drugs, you have to do several things. The anti-TNFs, they're fast. They're sub-Q, adalimumab, it's IV. If a patient doesn't want to do an IV, you're not going to give them an IV drug. it's not something they're going to go for. You talk to them about sub-Q formulations. Infections, skin cancer is present. Melanoma, the SIR is about 1.29 based on a meta-analysis Ed Loftus did, suggesting this is increased. Not very high. 1 in 7,000 is the approximate number of melanoma in the general population. High immunogenicity, often need immunogenicity modulators, so the immune modulators, oral 6-MP or methotrexate. Veto is initially thought to be slower onset in Crohn's. The median time to response based on Bruce Sand studies was 10 weeks. So this is something that, again, you have to look at the scenario. EIMs, it's not as good as in general, but it does work in some. Tofacitinib, it's not approved for biologic naive. You have to fail another agent, particularly an anti-TNF, based on the labeling. Although it works in that scenario, DVT-PEs in the RA patients is higher, not necessarily seen in UC. Zoster is 5 to 10%, depending on the dose, 5 and 10 BID. But now with the vaccination of the recombinant vaccine for zoster, this may be something that goes down substantially. Cytopenias and pregnancy, this is not something I'd rush to use during pregnancy, and I think Marla's going to talk more about that directly. And then ustekinumab on the EIMs is not as well defined as what I'll say, but it does help in some. And the same we see in Crohn's disease, so it's not something unique to ulcerative colitis, but you always have to say, is this the right scenario to treat the patient population? When do you stop? So if a patient is on an anti-TNF and they get optic neuritis, multiple sclerosis, melanoma, lymphoma, worsening psoriasis, the PASI score greater than 5% is when you have to think of stopping topicals, and that's the percentage area surface involvement with psoriasis. As a dermatologist would say, that's when it's a breaking point. If it's greater than 5%, then you start thinking of using something such as ustekinumab, which has dual approval and works phenomenally in patients that have psoriasis. If they get hives, wheezing, anaphylaxis, in other words, an anaphylactic reaction, it's game over. TB, high-level antibody, low-level we can work through. You start an immune modulator, you escalate the dose. Vedolizumab, you get a high-level antibody, and again, this is uncommon, hives, wheezing, anaphylaxis. TOFA, if you have a DVT or a pulmonary embolus, it's time to consider switching, and there's a suggestion of major adverse cardiovascular events. But again, it's not recognized that, again, Ed Loftus and the group at the Mayo did a meta-analysis, and they published that there's a higher MACE level in patients with IBD. So IBD itself gives you a higher risk of cardiovascular events, and they did not compare that data to that. So this is something that I go back to the FDA and say, look at that and see if the rates are higher. And RA patients are obese, a higher BMI, they're immobile, and they have known cardiovascular risks in themselves, so this does not translate to IBD as of yet, although it's guilt by association of use of drug. Ustekinumab, posterior reversible encephalopathy syndrome, uncommon, described in one patient in the literature, but neurologic event, and it is reversible. High-level antibody to stop, and ozanimod, bradyarrhythmia, AV conduction delays, posterior reversible encephalopathy has been described. Macular edema, that's a time to stop. If you're diabetic, you can get that. If you have MS, you can get that. There's other states as well. Or PML is as well potentially possible, not yet described, because of its mechanism of action. So these are when you stop. These are absolute things to stop with when you see the patients. How do you treat and optimize? And this I stole from Papa Michael's paper. There's a very nice review recently that looks at suggested drug concentrations for remission and also mucosal healing. I guess you want me to finish up. It's a subtle hint. So to conclude, biologic therapy is safe and effective for moderate Crohn's and ulcerative colitis. The biologics, the anti-TNFs, ustekinumab, vedolizumab, are first-line options for patients with moderate to severe ulcerative colitis and Crohn's who are failing other therapies or who have a poor prognosis and are appropriate to use prior to taking other therapies directly. TOFA is effective in ulcerative colitis. It is not effective in Crohn's. and both TNF naive and experienced, but it's only approved for the TNF experienced to date. Ozanimod is approved for both ulcerative colitis, moderate to severe. The clinical scenarios really dictate which medication is best to use. Is it an inpatient, an outpatient? Is it severe colitic? Is there a low serum albumin as well is another thing I didn't really mention. The anti-TNFs don't work as well. Tofacitinib works very well in that and is not dependent on albumin. We're just submitting a paper from the studies for publication on that. The extraintestinal manifestations should be looked at. Malignancy should be taken into account. And the rapidity of onset of action is another factor to look at when looking at things. And lastly, safety. If there's a severe adverse event, then it's time to potentially get back, throw the football to someone else and say, you're on the court. It's time to go. Thanks a lot, and I'll stop here. I appreciate the opportunity today.
Great presentation, Gary. We learned a lot. Yeah. So the next presentation is going to be by Dr. Marla Dubinsky. She's the professor of pediatrics and the chief of pediatric GI and the co-director of the IBD Center at Mount Sinai, New York City. She's a world expert in the area of personalized medicine, and she has a particular interest in pregnancy and IBD. So I asked her to talk on preconception, peripartum management of IBD. Welcome, Marla.
Thank you, Uday. So let's start by sort of referencing where does things get confused when it comes to women wanting to conceive. Gary noted that understanding the phenotype or the population that you're dealing with really helps dictate which therapy. I don't know why the slides are moving without me even just my presence. Is it? I think maybe the transition or something, yeah. Okay, so choosing your population is important when you're thinking about therapies. And all of the therapies, we've got a lot coming out over the next 5-10 years, as Gary showed you, sort of a pipeline. But interestingly enough, 50% of your patients are women, and a lot of them are diagnosed at the time of childbearing. So the question really comes down to sequence will matter, but also whether the patient is looking to get pregnant. Because currently, as Gary noted, tofacitinib, upadacitinib when it comes out, ozanimod, they are not recommended to be used in pregnancy, especially in the first trimester, because in the first 10 weeks, that is when organogenesis happens. So these therapies cannot be used in theory, although we've had a number of pregnancies in the trial. We do have some first trimester data, but in essence, you have to consider which therapy you're going to use depending on the patient that is sitting in front of you. These special populations dominate a lot of our decision making. And the reason why this is important is that there are a lot of misconceptions out there about the safety of our medications. And most of the reason why women are often wanting to stop meds or maybe choose not to get pregnant is fear, right? The unknown, lack of knowledge around particularly fear of IBD causing harm to my baby, fear of the meds causing harm to the baby, fear of passing IBD on to the baby, and fear of having a complicated pregnancy because of IBD. So imagine this is actually happening when your female patients are being diagnosed. And in my pediatric patients' onset, the parents are actually having this kind of fear as well. And what I want to say is that just by educating women on all of these misconceptions could actually change entirely this voluntary childlessness that a lot of our patients choose because of just the unknown. So this is really important to communicate the knowledge around, yes, you can get pregnant, and with the exception of a handful of medications, methotrexate, ozanimod, and tofacitinib right now, you can get pregnant on any other medication, and you need to stay on those medications during pregnancy, because the number one risk factor for all of the things that the moms are afraid of are due to inflammation, not to the medication and not due to being pregnant. So this is like an underlying theme. So in my preconception clinic, this is my extreme focus is all around disease control. If you get the disease under control, conceive under good disease control, you will have 10 months of a very happy gestation. So that's a really important concept to put across to women. Similarly, Fears about breastfeeding. Why are you choosing not to breastfeed? Fear of the medication passing into the breast milk, my baby actually getting sick. So the question really on the table is, can we again explain that you could breastfeed and there are very few medications that you can't breastfeed on? And so it's the same meds that you can't take during the first trimester. So it's actually a simple discussion, which is stay on your meds, not only during pregnancy, but also postpartum, because it's important that you do not flare in the postpartum period. So these are sort of important messages, and if walk away with anything, it's that the only thing that matters is we control your disease. That is really sort of the number one message we like to give to our patients. So this is an amazing project that myself and Marla Dubinsky worked on with the AGA called the IBD Parenthood Project, and we put a decision support tool. It was published in Gastro, and it really outlines sort of all the steps of pregnancy: preconception, what to do during pregnancy, oh my God, what to do during pregnancy, as well as what to do in terms of delivery. And I'm going to walk you through a few important teaching points for your patients when it comes to understanding the communication and preconception. So let's first talk about what patients want to talk about. And you can imagine that whether you're pregnant, which is the yellow bar, or whether you're preconception, the number one discussion point is safety of meds. So if you get that elephant in the room, the minute a patient is being placed on a new therapy, a female patient in particular, or is telling you that they're planning on getting pregnant, you should just go right in and talk about the safety of medication. Encourage them that when their OB tells them to stop, that they do not stop until they call you, because that is what is actually happening. Not a maternal fetal medicine doctor or a high-risk OB. They're not the ones telling the patients to stop. It really is the general OB. Also, control of IBD, explaining what that means and why it's tied to medications, and also outcomes of baby are completely and entirely tied to inflammation and nothing to do with the medication. So that's another sort of persistent message that we give to our patients. When it comes to fertility, just so you know, probably voluntary childlessness remains the highest among most of the diseases. And as I noted, there's no medication that is impacting fertility, by the way. That is not where the problem is. The problem is whether or not the medications actually are teratogenic, right? Do they cause any congenital malformations? There is some new emerging data that disease activity and chronic pelvic inflammation leads to lower AMH, which is anti-Müllerian hormone, which is a marker of ovarian reserve. So the higher the disease activity, the lower possibility of the fertilizable good quality eggs. So this is another reason to get your patients under good IBD control when they're telling you they were thinking about getting pregnant. And probably at the end of the day, the most important thing is to message the patients that if your disease is under control, fertility is the same as the general population, with the exception of two scenarios. One, of course, is the female patient who is IBD or not, is above the age of 35. It doesn't, one thing I tell women who are coming to seek and saying they're having difficulty conceiving, I'll talk about their inflammation, but I'll also tell them that they're 37 and they've undergone a J-pouch surgery. This is your highest risk patient for not having the highest level of fertility, and you need to move and send them to a fertility specialist and not tell them to come back in a year. That makes their eggs 38 years of age, and they still have the adhesions in their pelvis from their J-pouch surgery. So these are important, concepts that age matters the most. That's the number one predictor of fertility, infertility of everybody, not just IBD patients. And then you have to layer in a female patient who's had J-pouch surgery, because when they go in to dissect the pelvis and they take the rectum out to create the actual ilioanal anastomosis, that's when you get scar tissue and adhesions in the fallopian tubes. So I typically send my women who've had open surgery. I shall say in the era of laparoscopic, we don't have the same infertility rates, but it's really studied retrospectively and not a lot of patients, so we are currently studying that. But I do send them for a salpingogram if they've had open J-pouch surgery. Sonia Friedman recently, it's okay, thank you. Sonia Friedman recently published that women who've undergone Crohn's surgery, which I was surprised because they looked at time to pregnancy in women who've undergone Crohn's surgery, because we've talked always about UC surgery and we never talked about Crohn's surgery. And in the end, it does look like women who've undergone Crohn's surgery historically may take longer time to pregnancy. So again, my message is that if a woman who has had any type of IBD surgery, that they tell you that they're having trouble getting pregnant, please send them to either a preconception clinic, if you live in New York or the region, I'm happy to always see them, but also to a fertility specialist, because they know that there may be pelvic scarring, and it may be that they need IVF. This is a really important message as well. Next message of importance would be the consequences to uncontrolled disease. So there's many reports that have suggested if you have disease activity, you have higher preterm birth, lower birth weight compared to when you're in remission. And what we showed with the piano study is the same, that you have a 3.4-fold increased risk of miscarriage in a woman who conceives in an active disease state. So again, the messaging comes down to you must be in remission. And I like to say deep remission. Gary talked about deep remission. What does that mean? That means biochemically, mucosally. I don't know if we've reached histology, nirvana yet, but you know what I'm saying, that macroscopically at least the disease is normal. So then we look at what are the other things we need to do. Is I already mentioned that the OBs are typically stopping. Yay for gastros. We're the group that is least likely to stop a patient's biologic before pregnancy. Makes me happy. But you could see how horrifying it is that the primary care doctor, almost 8 out of 10 are saying, you need to stop your IBD meds if you think you're going to get pregnant. And as horrifying, 62% of OBs. So this is really what you're up against. So that's why your messaging is really important when you're managing women with IBD. And this is in Europe. Part of the problem is the narrative from Europe is that you need to stop your biologics in women around week 22, 24, so that when the baby is born, there's zero biologic in their bloodstream. Okay? Well, our data from Piano says absolutely not. There's absolutely no need to stop the biologic. We've actually studied over 1,000 women prospectively in the Piano registry, and what this slide is showing you is there is not one element of infection in any baby born to a mom taking biologics, even in the 3rd trimester, and therefore there's no reason to stop the biologic. Keep them on their cycle, keep them going, started after delivery in their usual cycle, but there's no reason now, almost 1,000 plus, 1,500 almost patients that have told us that biologics do not increase the rates of infection after delivery and even up to first year of life, by the way. Also, because moms are worried that potentially do we know what this is doing to the development, the cognitive development? Not to say that biologics make their babies smarter, but they had a slight increased ability to be more social. I think that has nothing to do, I think it was just luck. But at the end of the day, again, inflammatory control is more important, because babies, when their brain is going from flat to develop the gyri, you don't want it developing in an inflamed amniotic environment. So again, disease control is critical. In terms of, next, please. The mode of delivery, let's end with mode of delivery, just to remind you that this is a very contentious topic with OBs. Their societies are telling them stop doing so many elective C-sections and making sort of a general statement, not taking into account that in patients who have already issues potentially with continence, have already chronic pelvic floor damage, adding pregnancy to the pelvic floor and more pelvic pressure, that you do not want your patient, in my opinion, who has a J-pouch, for example, who's already potentially waking up at night, having incontinence, to weaken their pelvic floor even more with a prolonged vaginal delivery, as an example. Or, God forbid, a stage 3 or 4 tear, where literally it's the tear and connection between the vagina and the anus. So this is something that we see. So you have to be very clear with the patient when they're choosing mode of delivery. The only absolute contraindication currently stated today, I gave you sort of a relative, which is a J pouch. The absolute is active perianal disease and a rectovaginal fistula. Makes sense, right? You already have vaginal wall damage, so having a vaginal delivery won't be so great for the vaginal wall. We actually showed that the number one reason for C-section is OB related. So it's not like we're putting all IBD women into this category that you all need a C-section. But one of the most common things that obviously perianal disease or J pouch are typically the most common. And Bo, I'd love your opinion after if we talk about it. One thing to also note is we also recently published in the IBD journal that there's no impact on wound healing of C-section, even if you give the biologic literally right after delivery. So what we do to make it more convenient for moms is we sort of give them their biologic before they go home. It saves them from having to come to an infusion unit, possibly set up home infusions. They're nursing brand new moms. So trying to make it convenient, we show that there is no increased rate. So lactation overall, just to let you know that all our meds except for metho, tofa, and now ozanimod, I should add that, all our meds are safe during breastfeeding, for breastfeeding. Just remember, there's only one difference between a mom having a baby on biologics and a mom who's not on biologics, and that is that the baby should not be getting any live vaccines within the first 6 months of birth. And the good news is there's only one. That's the rotavirus vaccine. So it's not like, I don't think any of us in the room probably had the rotavirus vaccine. We survived. So I think that, explaining that it's not the mission critical vaccine and that MMR and chickenpox, which is at a year, no problem. They can get their live vaccine. And I cannot have a discussion about pregnancy without talking about what happened in New York City during COVID in March, April, and May of 2020. We were delivering women 29 weeks in a coma, delivering children. And so our biggest push, obviously, for those of us who manage IBD women on biologics who want to get pregnant or are pregnant is you must get vaccinated. This is a really significant outcome because of what happened. If you saw, the maternal fetal medicine societies and the OB societies were the first to come out and say women need to fall even into the category 1A, like us and healthcare workers. That's how dramatic the outcomes were in a woman who gets COVID. So this was a really big push. I manage a very complex Orthodox Jewish community, and every day I am up against them telling me that it causes infertility. So one of the biggest messages that also came out is our ability to communicate around fertility, because this has been the number one roadblock to us giving it to women of childbearing potential. So the messaging is very clear and has been pretty strong from us as well as from our MFM. So in the end, how should I counsel my patients? Education is really key. And also ask about their fears and please address it head on. There's no reason to skirt around it. It's all great news. There's absolutely nothing but good news when you're talking to a female patient. Disease control is paramount, and just remember to early referral for fertility treatment, especially in your women who are above 35 or your women who've undergone IBD-related surgery. Thank you so much.
Great presentation, Marla. So to wrap up the first session, you have Dr. David Schwartz from Vanderbilt. He's a professor of medicine and director of the IBD Center at Vanderbilt. And he's a very expert in the area of perianal Crohn's disease and fistulizing Crohn's disease, but he has a wide area of interest. And I think in the era of COVID, I wanted him to talk on managing IBD in the era of COVID.
Thank you, Uday, and I thank Rob and Shyam for the kind invitation. This is a little bit of a difficult topic just because things are moving so quickly. And actually, even when I put my talk together, which was only about 3 weeks ago, we hadn't even heard about the Omicron variant. So I tried to stick to things that we have really concrete evidence for in talking about this topic. We're going to go through briefly the background, talk about what we know about the outcomes of patients with IBD and COVID, some of the vaccine data in our IBD patients, and then just end with how I approach treating patients when they actually do get COVID and kind of just principles to think about when in treating IBD patients in the COVID era. So if you can all remember, and a lot has changed obviously over the last 2 years, but if you can remember back when COVID first started, there was a lot of concern because most of our patients are on immunosuppressive medications, and we didn't really have any data as to how they might might do. And thankfully, investigators came together and formed the secure registry and allowed us physicians to enter in the outcomes of patients who had COVID with IBD. And I think a nice example of how the scientific community can come together in a time of crisis and really answer some really important questions. And our patients were really needing these answers as to what to do. And so this is an observational cohort, and you can imagine that there's a lot of reporting bias because after you've entered a few of these patients in, you tend to just put in the people that have had bad outcomes. I'm definitely guilty of that. We did very, very well initially in entering everyone, and then as we sort of saw the same thing happen over and over again, we sort of dropped off. But it does still provide very helpful information. So the first iteration of this came out in early 2020 and looked at 523 patients with IBD and COVID. It's primarily from North America. And what we saw is what we're seeing in the general population. The things that were associated with bad outcomes included advanced age, if patients were on steroids, and how they were doing sort of overall, the number of comorbidities the patient had. So that was very reassuring. It didn't appear as if our medications really connoted any additional risk in outcomes when it came to COVID. This is some of the updated information that was just published recently, and you can see here the outcomes on the far right, which is ICU, ventilator, or death outcome, obviously the hardest endpoint, and as patients got older, the worse they did, and that's certainly true in the general population as well. As you'd imagine, if people who are the sickest tend to do the worst if they get an infection on top of their severe IBD. And so you can see those that have moderate to severe IBD had a slight increased risk of worse outcomes. So ICU, ventilator, death, 6% of patients with moderate to severe disease had that endpoint. And when you look at the medications we use for IBD, similar to what we saw initially in the general IBD population, really the only medicine that was related to really bad outcomes was the use of steroids, and you'll hear me mention this over and over again. So really hammering home the need to really consider either lower doses of steroids or hopefully avoiding steroids altogether to help prevent some of the bad outcomes we see if someone were to get COVID while on higher dose prednisone. Now, the initial concern, again, as I mentioned, was that all these patients on all these immunosuppressive medicines, in particular anti-TNF agents or thiopurines, that we might increase the risk of really severe outcomes because we're suppressing their immune system. And you can see here from this study that people on TNF monotherapy had a very low rate of severe COVID. When you look at thiopurine monotherapy, there is an increased risk of bad outcomes. And even though the TNFs may have a little bit of a protective effect, the thiopurine effect really outweighs that, and in combination therapy, patients still have a higher percentage of severe COVID. So let's shift gears a little bit and talk about the COVID-19 vaccine. A lot of misinformation, a lot of concern over this. In my population in Tennessee, which is a very low vaccination rate state, only about half of my patients with IBD have actually gotten the COVID vaccine for a number of different reasons, but a lot of which we'll talk about in some of the data I'm going to present now. The first study the first concern was perhaps because of the medication I'm on, the vaccines won't work, so why should I get it anyway? The first study that came out was from the UK, and they looked at over 1,200 patients who were on either infliximab or vedolizumab, and it's important to remember that the UK adopted a little bit of a different strategy in rolling out the vaccine. They opted to get as many people the first vaccine as quickly as possible, and then if they had vaccine left over, to get that second vaccination on schedule. So you'll see a lot of the data initially from the UK looking at only the rates of seroconversion with one vaccine. So this is, again, the primary first vaccine, and you can see lower rates of seroconversion on those who are on infliximab and immunomodulator use, and this obviously raised a whole lot of concern for those of us that take care of patients with IBD. But thankfully, we got additional studies that looked at the effect after that second vaccine. And first one is a Dutch study. This looked entirely at patients without IBD who had other autoimmune diseases, but were on very similar immunosuppressive medications, and they looked at the conversion to the spike antibody protein. And you can see here very similar results to the British study. Those on TNFs or those on combo therapy, in this case with methotrexate, had lower rates of seroconversion with the first vaccine, but thankfully after that second vaccine, the seroconversion rates came up nicely, although you do still see a little bit of a lower rate on those on anti-TNF agents, with about 86% of people seroconverting, and this is what led to the recommendation a few months ago for that booster vaccine in those that were immunosuppressed. Similarly, the response rate was looked at in the COVID registry. It's very small print, I'm sorry about that, but at the bottom, the take-home point is at the bottom, you can see nice seroconversion rates in all patients, all the different medicines we tend to use for patients with IBD. Again, those are on combo therapy, slightly lower, but 88%, but still good. This is looking similarly at patients who had both vaccines. This is at week 8 after the second vaccine, and you can see the seroconversion rates given the different medications. And generally, patients did well, but you can see it getting less and less as we get to the far right, where you have the lowest rate of those on corticosteroids. So the next question was, well, maybe I'll respond to the vaccine, but will it actually protect me? And I think this is something that hopefully we've answered by now, but you still hear this come up over and over again in the media and among people who are anti-vaxxers, that the vaccine doesn't actually prevent people from getting COVID or particularly severe COVID. You can see here from this VA study of over 7,000 patients compared unvaccinated to fully vaccinated patients with IBD. The light green or blue line it's a survival curve. Those are the ones that are fully vaccinated. So you can see the two curves really quickly diverge. Those that were vaccinated were prevented from, had a reduced rate of COVID, in particular, and a higher rate of survival. And then the last item of concern that the patients will bring up is that I don't want to take the vaccine because I'm worried I might flare, or number two, it may not be safe. The rate of adverse events with the vaccine might be higher because of my disease or because of the medications I'm on. Purple are those that are not on immunosuppressive therapy and not on advanced therapy. Greens are those that are on more advanced therapy. The darker the line, the more severe the reaction. And essentially the take-home message from this slide, it's a little busy, is that there really was no difference in adverse outcomes in those that received the vaccine. I will tell you anecdotally, I have had a patient or two flare when they receive the vaccine. The vaccine is made to be immunogenic, so we do warn them, but the numbers are, I can remember, maybe only 2 or 3 out of thousands of patients. So the benefit of the vaccine still by far outweighs the risk of a flare after getting the vaccine. And then just looking at this in a larger population, this is over 5,000 patients who received the COVID vaccine versus over 800,000 non-IBD patients. And you can see on the far right, outlined in green, the outcomes in the IBD compared to the non-IBD cohort. And again, the take-home point is there really wasn't any increased risk of any immediate adverse events or adverse events of special interest, and particularly hospitalization for flare, other causes in our IBD patients who received the COVID-19 vaccine. So again, very reassuring data that I share with our patients, but I'm sure you've all had the same experience. For most people who are not interested at this point in getting the vaccine are probably not going to be convinced to get the vaccine, but we still share this information with patients, and hopefully we'll continue to do so and hopefully convert some of those patients to decide eventually to get the vaccine. The other thing I hear is that patients have heard about the risk of blood clots after the COVID-19 vaccine, particularly in the single dose vaccinations. We do have a higher rate of thromboembolism in our patients with IBD, so perhaps the combination may be doubly worse or triply worse. When this has been looked at in a VA population, there did not appear to be any increased risk of thromboembolism in those IBD patients who received the vaccine. And then lastly, I just wanted to talk about the care of patients with IBD who do get COVID. It's unfortunately a very common situation, even in those that are vaccinated or unvaccinated, and we need to know how to approach those patients. And there's some common take pearls to think about when this does happen or before this does happen. There we go. So the first thing to keep in mind and to tell patients that just having IBD, the patient is not more susceptible to COVID. There was some concern initially when COVID first started that this might be the case, but this has not been shown to be true. The IBD medications we use generally to treat patients with IBD do not increase the susceptibility for patients to get COVID. It's really important to not forget about the other vaccinations that patients should be getting routinely during COVID. So definitely want to encourage the COVID vaccination, but don't forget about the flu vaccine, particularly now as we're going into the flu season, Pneumovax and all the other standard vaccinations we recommend for our patients. We have, I think for a while there, we were avoiding the shingles vaccine because we were worried that the symptoms after shingles vaccine may be confused with COVID. I think we're beyond that point now, and we need to really continue on with our routine vaccinations to make sure our patients don't get off schedule. And then kind of the key treatment pearl is really try to limit the use of steroids, particularly above 20 milligrams because of those bad outcomes I showed you. So when you are thinking about starting someone on steroids because they're flaring, potentially think about could there be an alternative agent I can use, or what is my exit strategy going to be so we can very quickly limit the amount of time that patient is on higher amounts of prednisone. Very important to encourage medication adherence with their IBD medications to prevent flares. Seeing this less often now, but certainly when COVID first started and we weren't seeing patients as often in the office before telemedicine sort of got rolled out, we were seeing patients back via telehealth medicine or in clinic 6 months later, and they had stopped their meds without telling us, and that led to some very bad outcomes. So it's really important to share the outcomes on our medicines with COVID and really stress the importance of not flaring and staying on their meds so that they stay well and can avoid bad outcomes. And then lastly, if a patient does develop COVID, this does happen frequently, recommend holding the immunosuppressive medication, usually about 2 weeks. That's generally long enough for the patient to clear the infection and restart the medication. A lot of our patients will get this and be asymptomatic. So one approach to this is to do 2 negative tests approximately 24 hours apart. Not generally doing that now, so what we're usually doing is waiting about 8 days after onset of symptoms, and then they can restart their medications, but this is definitely on a case-to-case basis. So thank you very much for your time. Again, I appreciate the invitation to speak.
Fantastic presentation, David. So we'll wrap up the session for this morning. I think we'll more have the case discussions and question and answer sessions next. So we'll start with the case discussion. So I think I have 2 cases. We have 20 minutes to wrap up. So I think we'll start with the first case. So it's a 28-year-old white male. He's a resident physician. He's out for a second opinion because of continued bleeding per rectum, chronic diarrhea, and abdominal pain for 6 months. He had 6 to 8 bowel movements a day with mucus and blood, tenesmus, urgency. He was treated prior with ACE agents and is on adalimumab Q2 weeks for the past 5 months. And he actually required 2 courses of prednisone in the past 6 months since he was diagnosed. Past medical history significant for hypertension and ulcerative colitis 6 months ago. No single history, no history of cancer, not a smoker, social alcohol use. He just takes amlodipine for his high blood pressure. So physical exam is an obese white male. Rest of the exam actually looks pretty uncontributory. Obvious labs are significant for mild anemia is because we bring up the albumin. Albumin level is 3.5 for a minute, bring it up there. The calprotectin is 840 and the CRP is 12. And the colonoscopy showed obviously severe colitis on the left side up to the descending colon with a Mayo of 3. And the rest of the colon beyond that was Mayo 0. And actually he was on treatment with 5 months of adalimumab before on this at the time of the colonoscopy. So the questions, we'll start with the first one. Was adalimumab the right treatment choice based on current evidence? Is there a role for any combination therapy, or do you want to add something on top of it? Do you want any labs beyond that? So we'll start with maybe Gary. Let's talk more about this. So was adalimumab the right treatment choice, Gary?
So it's a good choice, but it wasn't optimized in him, clearly. I think that's the key question we always get, because drugs can work when given appropriately. And every 2 weeks is often not going to work. You look at that, and that's like an untreated patient.
Yeah.
So depending on the severity of symptoms, one might say this is really a failure. But again, if a level is 3 and then you give a drug, you increase the drug, and it goes up to a level of 9 or 10, then you might be in good standing. So it all depends on how sick the patient is, and they're rather sick. I'd say they have moderate, severe disease, without a question, more on the severe end. So
you wanted the labs, you wanted the adalimumab levels and antibodies?
Well, you want to get your albumin, see what that is.
Yeah.
If the albumin is 2, then I'd say this is really an unlikely scenario to benefit. If the adalimumab level is very low as well, then this is something clearly, that is able to be pushed if the antibody is negative. If the antibody is positive, it's game over, high level.
Yeah.
But you might want to do concurrent immune modulator if it's an intermediate, methotrexate, as opposed to, and this is how old again? He's
28.
28. So I would not use azathioprine or 6-MP because your risk of lymphoma is about ninefold under the age of 35.
Okay.
Can I make a comment?
So, I want Marla to go talk about it.
I
Just
just
a
want to.
reminder for everybody, if you can speak into the microphone and not speak to Uday,
Yeah.
so everybody can hear you.
But we want to speak to him. Okay, so a couple of things. I mean, I think you made him intentionally have a higher BMI, and the reason for that is important because when you looked at supplemental table in the ULTRA trials, which was for UC for adalimumab, if you're above 70 kilos, if you have a Mayo endoscopic score of 3, or if you have a total Mayo score above 9, this patient, adalimumab is actually not effective, to be fair. And when you look at the network meta-analysis that Sid Singh published, and there's a couple more that have come out, and I have to be honest, is that adalimumab is the least effective UC therapy. This is based on pure clinical trial, not head-to-head. And this was a naive patient, so you can glean that from the Varsity study, that adalimumab did not perform as well as vedolizumab. I mean, we have that one head-to-head. So I just wanted to point out that patient characteristics are so critical, not just what we have in our fridge as samples and ease, because in a UC patient, it could go quickly through ADA, non-responder, and quickly to colectomy. So it's really important that you choose wisely your first UC med. But taking Gary's point, let's just say you do it and his adalimumab levels are good. I think a big question that I struggle with often is, does that mean they're a TNF failure, or is Remy on the table? So I wanted to just put that out as a controversial topic.
All good questions. So
I'll
we'll try
make
to,
one more
Yes,
point.
Gary.
We don't practice by network meta-analyses. Even though the AGA, and this is a political statement, published guidelines based on network meta-analysis, there are many people who disagree with that approach.
Okay, so I use Varsity. I
But
brought
I'm
out
not
a
saying you.
non-network.
I'm not critiquing you. I'm not critiquing what
case.
you
So Gary, I think I'm just going to go with the next one. You see, Varsity trial clearly showed that vedolizumab is superior to adalimumab. So, and you wanted the question of trough level, it's 12 with no antibodies. So what do you say?
Game over.
Game over, yeah.
Well,
Really?
Game over for adalimumab, not
fine.
for
Yeah,
infliximab.
That's the question.
adalimumab.
Okay.
So
Not for colectomy. by any
I have one, this may be a little bit off topic, but one of the things, Bo mentioned that he doesn't really do combo therapy much anymore, and I had the same experience. I've had 2 people get hepatosplenic T-cell lymphoma, so I'm really gun shy as well. So what we're doing currently is using the HLA typing to decide who we're going to do combo therapy on. So if we were to do, let's say, Remicade next, we can talk about that. That might be something I would check at this point to see if combo is needed or not, and to help sort of personalize the risk in that patient.
So
So
just a
David, do you want
reminder.
to comment more on the HLA to the audience?
So I always get this wrong, so someone please help me. It's HLA DQ
15.
105.
105, yep. And so it's either a standard celiac test, you can get that back, or there's a separate test that will just check that and helps inform whether or not the patient is at increased risk of developing antibodies to an anti-TNF. If they're positive for that, then their risk is quite high. So in those that are positive, we do combo therapy for a defined period of time. And for those that are negative, we go with monotherapy and try to optimize levels.
Yeah, let me state that even 40% of people who are not carriers, who are on combo, still could get antibodies, and that's because you have to optimize the drug early. So it's almost yes, because you're going to decide, am I going to use combo or not, but you can't do it without optimizing.
Yeah, you could argue for optimizing therapy even without combo, as Marla does quite a bit, I think. Be proactive in monitoring, checking levels at week 5, week 8, week 12, depending on the drug you use, and making changes in therapy right away. So going back to that question, so trough levels are good. The WASHI trial showed Vido is superior to adalimumab, published last year. So given this, the next treatment option he brought about Remicade, infliximab as an option. We can also think about vedolizumab as an option, but we brought him all the different options. He says, I'm a resident physician, very busy. I'm in ICU next 3 months. I'm very busy. I cannot go out get the infusion. So he's totally against infusion-based medications when I brought it up. Why? So next...
Tofa's on the table, but he's hypertensive, he's obese, so you're going to probably be a little concerned about maybe DVTs or prophylaxis, and you would have to monitor him pretty closely, get his baseline lipids. And
So although you say that, there's not good data that suggests in ulcerative colitis there's a higher risk. Bill Sanborn published data for all the trials that we didn't see that. It's the RA patients that had the higher risk.
Absolutely. It's just, do you want to, in someone who's 28 and meets some of the RA criteria? Should you be cautious?
I'm being the devil's advocate.
Yes.
I'm your
That's good. I like that, yeah.
I'm on your shoulder looking down.
David's over here is my angel. Gary's over here.
I love that. Can we quote you?
Okay, we discussed all the different options. I brought him infliximab because I believe that infliximab will still work for him. I don't think adalimumab levels will determine I don't think he's a primary non-responder, I believe. He could have responded to infliximab, but he was totally against it. So he wanted something oral. That's what he wanted in his practice. So I said, okay, we'll go with Tofa. And his lipids were actually not high. I think his lipids were normal, so thankfully. So he got the shingles vaccine, and actually he recovered really rapidly. Within a week, he said, I feel like a new person. He called me and said, I'm in the ICU, but I feel like I never had disease ever before. He felt great. He had 1 bowel movement a day, no blood, no mucus. Repeat FCP after 8 weeks of treatment was 28, and a CRP was 1. But interestingly, he said he went back and ate something in a restaurant, and 2 days after he had symptoms come back, he started getting like 10 bowel movements a day, bleeding, diarrhea again, around 10 weeks of treatment. So we checked labs again. Repeat FCP was 1040. He's still on 22 milligrams once a day treatment. Nothing has changed. We didn't drop him down to 11. We just continue the same dose. So what happened? And do you see that in practice quite often?
Sure.
Yeah. So this time we'll change gears maybe. David Schwartz. David?
Yeah, I guess I would want to check his stools first to make sure he hadn't picked up something that sort of triggered a flare. So I'd start with a stool study.
Yeah. The C. diff was negative. So he was negative. No infection in the workup. Anything else, Marla?
What had happened, by the way, with his steroids? I didn't get. Is there a steroid?
He never started on steroids at all.
Oh.
He was induced with Tofa directly. I never started him on steroids.
So the
Nothing
question
happened
you
with the
always ask,
steroids.
are you taking the drug? Is a very good question to ask.
He was taking the drug. He is very compliant. At last, what he told me. Yeah.
So it's tough. We saw in Octave that some patients needed 16 weeks, and 8 weeks wasn't enough. So the question is, if you had some improvement, I'm not saying this is the end game here, is to say, should I start you on rectal therapy? Is it urgency and stuff? Maybe it's rectal related, give some rectal therapy, plus or minus corticosteroid, or not at this point, to see if you want to give it a chance. Otherwise, you're again faced with that fork. Do you add ustekinumab, for example, and try and see if you go completely out, or do you say to him, I know that you're busy, but infliximab may be the right option at this point, or surgery? Never not an option.
Or he's flex-sig deficient because he may have CMV is another thing to contemplate on the table. He's immune suppressed. He's been on it for a while.
Yeah, I would probably do a flex-sig then too, if the stool studies were negative.
Yeah.
he actually, we gave him topical steroid treatment because most of the symptoms are more urgency, not actually like bleeding diarrhea. It's like urgency, going to the restroom. So I put him on topical steroids and continued the same TOFA. And actually said within a week, he started feeling better again. So I don't know what triggered that thing. And this FCP, again, we repeated it in 2 weeks. It came back down to 80, which is unbelievable. So I don't know what triggered it. I couldn't explain this rapid response within 2 weeks, but it is responding, thankfully. But I've seen patients like this who do not respond after 10 weeks. And I've always seen like patients who have anti-TNF exposed tend to flare up when they drop down to 11 milligrams per day. At 16 weeks, when they drop down, they flare up. So do you keep them on long term, if you can, for a longer time? Gary, do you want to answer that question?
I'd say the one thing to bring out is a stool culture is inadequate in this scenario. An enteric pathogen panel is really what you need to get.
Yeah.
And we've converted our entire system to enteric pathogens because you miss E. coli and a host of other things, and that can come and go very rapidly just like this.
He reported that he ate outside for a couple of days, and then he had symptoms flared up, and then within a week he went better.
E. coli we pick up a lot, and other things, Yersinia, things that you might not detect right away.
So
And-
going back to the question again, Tofu, when do you drop his dose at this point?
It depends on the patient. I don't really follow the guidance per
Yeah.
se 100% and say, okay, you've had 8 weeks, I'm going to now drop you to 5. Most patients I keep on the 10, to be very frank, and I follow them. There's data that comes about because if you drop, you don't recapture everyone, and
That's
that's
correct.
part of the issue. So it depends on the severity of the disease, where they are in the course of their treatments regimens, and what's at risk, what's at stake. And this is a patient clearly doesn't want to miss work, doesn't want to do things. The risk is relatively low for DVT-PE, so it's a shared decision-making at that point that you make with the patient, discuss with them.
I would probably rescope them at week 16 and use that as my treatment, the decision. If they were in mucosal healing, I'd feel a lot more comfortable dropping to 11.
Yeah, I mean, the problem is also in the riveting study, which is the post-marketing commitment for Pfizer to the FDA, which was they took patients who were on at least 2 years of 10 in remission and de-escalated, right? So that's one group, but that's after being on it for a long time. If you take the patients from the maintenance trial who were on 10 for induction and at 8 weeks reduced to 5, there are patients who flare. So I think without having deep remission, this is where I think this concept of deep remission for UC in someone who is a hard-to-treat person, I would say you definitely want to get to deep remission before you consider de-escalation. Remember, the label says lowest effective dose. That gives you some flexibility to say, I've got a refractory patient who I'm like, at the end, that scope was not great. This is a patient who I may, sorry, he doesn't want me talking to Uday. This is a patient that I would be considering that they could go to colectomy pretty quickly. So you are going to want to sort of be diligent. And as Gary said, you always have to weigh risk of disease versus risk of therapy in a young 28-year-old. That is really an important.
So Uday, it's like I would like to make some comments on this, right? Everybody roll back to the Humira, right? The adalimumab. Before you jump down drop the Humira that time, I think if my practice would be, I will give the first of all continue Humira. I will give the Euceris tablet. I use the steroid form, both together, and then you know what? You have nothing to lose. 2 weeks later, I always use a scope. Office-based scope, no sedation. You only go this 10 centimeters, see the response or not. It's like I always say, when you started some biological agent, any biological agent, like marriage, right? You don't give up, right? So they say, like, don't give easy because divorce is ugly. Now you burn out all the anti-TNF alpha.
But he has no response, Bo.
Yeah,
You see Mayo 3. You think he'll respond within another 2 weeks?
Or you will say this scope. You take a look, and then you can increase the dose. And of course, I
levels
agree.
are good.
I
We're going to
agree.
increase the
I agree with Gary. You need to check the albumin level, right?
His albumin level is good, actually. I mentioned 3.5. His albumin is very good.
So that's why I think this like you give more chance. And then regarding the TOFA, same thing here, right? Why not use the Euceris tablets rather because the disease is 40 centimeters, right? You respond to another thing is if you happen to be the Flexic, now I think the Flexic one of the biggest biggest predictor for disease progression is not only the disease severity, is disease extent. You have a 40 centimeters disease, now you go there as now the 60 centimeter. Then you really be very careful. You may do REMI. So otherwise, this patient will end up with a colectomy. I agree with the GI pathogen panel. It's very important, especially like a big city like New York. We actually estimated 10% of the people we order for the disease flare-up. You have Yersinia, you have Salmonella, and you have the various kind of where the bugs. Yeah. Thanks.
So just for a take-home message, 2020 AGA guidelines recommend vedolizumab or infliximab should be the first treatment choice for bio-naive UC patients, just based on the varsity trial plus Vedo. And infliximab has been the gold standard for treatment. I think ozanimod is a new kid on the block. I think we'll need more data. But there's one study from Marla, I think earlier this year, you had some it works really well in early option. So something to consider is an oral option, early option, works very well in bio-naive patients. So that could be an option down the line. But at this point, tofa should not be used in a bio-naive patient. They should have failed anatina because of obviously the FDA black box warning. So I've seen a lot of patients refer to us started on tofa without being tried on anti-TNFs. So just a take-home message, always should try anti-TNFs, fail anti-TNFs before you can start tofa in practice. Obviously, CRP and FCP is so integral. I probably do it pretty much every time when I see patients flares up before you want to make a big decision on taking treatment. Because a lot of times patients are not amenable to scoping all the time. It's not possible to scope everybody all the time. So it's important to make a decision based on that.
So Uday, one question I have is, why not use secukinumab or vedolizumab? Why must it be an anti-TNF? And I think the FDA needs to change what they say in their posture. I think it's a mistake. It should be a biologic is
Biologic
the key.
exposed patients.
Prior to tofa.
Yeah, or
Makes. So second case, I think extension of what Marla talked. So again, just saw her a few weeks ago. 26-year-old white female who recently moved from New Jersey, was referred for UC management. Is actually 22 weeks pregnant when I saw her. Had chronic diarrhea, nocturnal symptoms, mucus and stool, active disease, 8 bowel movements a day, but no blood, but had tenesmus urgency. She was actually on infliximab for the past 2 years. Never had checked levels for the last 2 years. Was actually flaring for the last 1 year and never followed up based on that. So she was actually having active symptoms when all this happened. She actually was on prednisone in the last 6 months, at least 2 doses. Again, recent diagnosis of UC, no other particular social or surgical history. She was actually on prednisone 10 milligrams Q-day, was tapering down when I saw her in the office. So this is a challenge. Obviously, we want to have this scenario from happening because you want to have a patient well controlled before they get to this stage. So this happened. So patient comes in. She actually had before pregnancy in May 2021 of this year, she actually had a colonoscopy, showed Mayo score of 2 all the way to the transverse colon. When we saw her, her labs were significant except for a high CRP and calprotectin and a low hemoglobin. Albumin is 3.9 still, that's pretty good. So this is where we stand. Obviously, she's not responding every 8 weeks treatment. We don't have any levels, so we'll have different options to think about. So either you do the same dose, the same drug, it's not been working for the last year at least, increase the frequency every 6 weeks, 4 weeks, or you check the levels and antibodies and make a decision based on that, add an immunomodulator, or switch to other biologic or small molecule treatment. So these are different options you're presented with. I'll start with Marla. So what do you think the next step should be?
So I would sort of do a few things. One, of course, add some rectal therapy immediately because the patient is describing a lot of rectal symptoms and they're safe in pregnancy. And they're not going to, a lot of women are worried they're going to stimulate delivery, which they're not. So you can give them and maybe even budesonide foam, because it goes higher. It goes up to 40 centimeters and it's quite effective. So I would probably use something beyond just a suppository because you told me she had extensive colitis, right? Mm-hmm. Yes. Second, I would check infliximab levels and also immediately escalate her. You're in a very precarious situation here. This is a 22-weeker. And there's high likelihood she could go into preterm labor. And so you got to bring out your guns. Steroids are not necessarily a gun in this particular case, but it could be, I'd want to know, was she better at 20? Just while you're doing all these things, you want to at least put her on the lowest effective dose of pred potentially. But I think your rectal is going to help. Get a level, increase her. I would do 10Q4 for a couple while I'm waiting for the level, try and get authorization. By the time you get it back, you'll know whether she's just a failure to TNF and her levels are 28. For levels are 28, you need to move on to something else. And for me, my second choice would be ustekinumab in a patient who's failing, because TOFA is on the table. Like I said, it's not like you can't, if you had an emergency and your biggest thing is to get this woman under inflammatory control and she's refractory to steroid, you're past organogenesis. So 10 weeks is long past. If you did need to bring out something to help control the inflammation because your sort of patchwork isn't working, then you can. But the key would be to get her on something sustainable for a lot maintenance, because she hadn't been responding to this for a while.
Right,
so it's
yeah.
the question is it just, does she have antibodies? It goes back to the same thing that Gary was saying. Does she have antibodies? Does she have low levels? Is she a mechanism failure, infection, and rectal stuff? So I'd say not starting an immunomodulator, please, ever in pregnancy, because what if they get pancreatitis or some reaction to an immunomodulator? That's never good, and metho wouldn't be appropriate. So you're really trying to optimize what you're on, a little bit reactive and blind a little bit, get your auth in, but get your level, and then make a decision. Yeah.
That's great. I would just add, I would probably also do a Flexig. Just you're in the second trimester, so it's safe, and just want to make sure you're not
What's it gonna
missing
tell you?
CMV.
CMV.
Yeah.
You're really into CMV today. Yeah, so.
CMV is a big topic today. Looks like that.
Wow.
Yeah.
And she's been on steroids for a long time,
Yeah,
so that's why. However, to be fair, she hasn't been responding for a while. This isn't like a new
Yeah.
story, but you're right.
So going back, I think we did check levels. And levels actually 32 with no antibody. So Marla, I think the new predict infliximab levels where you don't need to wait like for the week 8 trough levels to be done. What do you think is the role in practice?
So you got a level when, by
At
the
week
way?
4.
At week 4.
Yeah.
So week 4, 32 means that you're going to be therapeutic at week 8.
Yeah.
As long as your level is above 27-ish at 4 weeks, you know that you're going to make it and your levels will be good. And just as a sort of a cheat is that every 2 weeks, your level goes down by half. So at 6 weeks, it would have been 18. And at 8 weeks, it would have been 9. That's pretty good. So you're probably, understand I'm going every 2 weeks is the half-life-ish, so I'm decreasing the level that you just told me every 2 weeks. So I think to me, this is someone who's,
A primary non-responder.
probably not doing
because
well.
when you asked the question again, you said, I never felt better after starting infliximab
Yeah.
for the past 2 years. Never
Yeah.
felt better.
Again, endoscopically, and I'm sure but she was on steroids twice, so she
Twice.
probably had a steroid high for like 3 months out of each time she was given steroids. So I understand what she's saying. It's just she's not responding.
Yeah.
So, yeah.
So actually, we just started on ustekinumab because I think once we got the levels, actually started on ustekinumab just because I think, and we did a MFM consultation because I think she came from New Jersey. She didn't have an OB even. She came directly from New Jersey. GI physician directly referred to me, and then we got an MFM consultation with our group here. And so what is the next step after this? Obviously, we're going to start ustekinumab, and then how do we manage biologics during delivery and postpartum period? It's a question to answer.
Okay, so she was 22 weeks, and now let's say she's
26.
26 now.
Yeah.
So then you're going to give her 8-week at week 34, and sort of the timing is goodish because then you could just give her next one after delivery. I would get, this is again not based on great science, but I would get a ustekinumab level before her sub-Q just to see if you do need Q4, because if
Yeah.
it's 0, you may need Q4 just because, again, this is a tenuous scenario, it's pregnancy. But it looks like levels, remember that infliximab levels go up in the 3rd trimester, adalimumab levels go down, and it looks like ustekinumab levels stay the same. So this is what we're seeing. There's not like a ton of data, but it probably mimics the same as what you would get in a non-pregnant patient.
Yeah.
So I would just give it to her when she gets home. No issues with breastfeeding. And as a reminder of all the drugs, this is the only biologic that was actually tested in primate placenta, which is the closest placenta to a human, which is why the FDA even puts it's safe up to 100 milligrams per kilogram. We use 6, right?
Yeah.
So it's the only drug that we actually have the best,
Best data
the
for.
best pregnancy to human placental model.
So Gary, any role for vedolizumab in this patient who has failed infliximab in your practice?
I think veto is possible in colitis. It reacts really, rather rapidly. It's a fast response. It's not like it is in Crohn's disease. This is certainly an option, and I think that the level of severity of the disease and the rapidity of onset of the drug are some of the key factors that one has to look at. I think escalation of the steroids is a key thing in the intermediate time frame. until a couple weeks, but not very high dose. I'd go on a low dose because the
Yeah,
rapidity
she
of
actually
onset.
felt better on 25, so I actually put her on 25 milligrams until she gets this drug kicked into the system.
Because
Yeah.
remember, by 6 weeks, you may have total response.
Yeah.
It's something you have to look at. But I think that's appropriate. And I don't change drugs in pregnancy based upon anything at this point in day, like Marla says. I think the key is keep on the drug. Keep it's not the drugs that are the enemy, it's the disease.
I think the take-home message is mentioned. I think patients who fail infliximab, ustekinumab, or tofa are great choices. Obviously, with the pregnancy, I prefer ustekinumab. Vedo is a good choice, but I think in infliximab failures, I think it's less likely going to respond, I think. So, and we've seen it quite frequent in clinical practice too. We don't have the same response as in bio-naive patients. And I think all biologics can be safely continued throughout pregnancy. Probably the most important take-home message from all of us here, that don't stop the medication. And obviously, you don't want to use tofa, start tofa, or ozanimod, or methotrexate in patients who are planning pregnancy or contemplating pregnancy because of teratogenicity. So I think we'll have questions from the audience to wrap it up. I think within the Orlando Health System, we actually have a collaborative work with MFM people. So we actually have a combined clinic with MFM and us together, where we manage patients. So we do 1 half day every 2 weeks. We're planning that way, and I think it'd be a good transition for patients who are high risk pregnant to manage with MFM together. It's a very important thing. MFM should be a part of the treatment plan for IBD patients who are pregnant. We also have the pediatric adult transition clinic as part of the transition from Arnold Palmer Children's Hospital to the IBD center with us. We also have a pouch clinic establishing where we see patients with courtesy of Bo. We want to establish something where we work with colorectal surgeons to establish patients with J pouch, K pouch, and S pouches and manage all of them. Yeah, Rob?
Out in
Last
private
question.
practice over the last 35 years managing pregnant patients, the biggest factor that we have in terms of stopping the medication are the pharmacists and the non-GI extenders. Every patient that I have surveyed over the last 30 years have told me it's not the OBGYN, but it's the pharmacist when they go in to renew their meds for the non-GI extenders.
I got to figure that out. That's quite, that's disturbing actually, because that's who they rely on when they go pick up their meds, right? So interesting.
So we talk to patients before they try to conceive, and they recognize this, and we warn them of that. There are many people that wear hats that say, I'm a physician, but they're not physicians, or an NP or a PA, and they really don't have the credentials or the knowledge. And we see it in all avenues with regards to things, so it's dangerous.
Okay, I think we have to
wrap it
this
up, actually.
I want to thank all the discussions. There were a little bit too many CMV questions, so that's why we ran over a little bit. But I really want to thank the panel and thank Uday.